Okay, everybody, let's go ahead and get started. This is Rob Podlugger, and I want to welcome everybody today to the webinar in which we're going to explore how Siemer Institute partners successfully implement trauma-informed care into their family stability programs. And to those of you who shared your stories, thank you for contributing your knowledge and your expertise to benefit the Siemer network. I'm very excited today to introduce to you Dr. Amanda Scott with Illuminology, and she will present the basic principles of trauma-informed care and share how the Siemer network programs are including trauma-informed care principles into their service delivery. As a reminder, these slides and briefs that have been put together will be available in the Resource Center. And also, if I could, one more time, ask everybody, if you are on, to place yourself on mute. And if for some reason you do need to step away, do not put us on hold if you're on a phone, because we very well could hear some background music. So I'm going to go ahead and turn it over to Amanda.
Good afternoon. Can you hear me? Okay. Thanks for joining us, everyone, and thank you for the gracious introduction, Rob. This afternoon, as Rob mentioned, we're going to try to cover two primary objectives. So the first thing we want to do is help United Ways and service providers better understand trauma-informed care generally. So I'll walk you through the definition of trauma-informed care and some high-level insights about how trauma-informed care relates to other approaches that you're probably familiar with. Second, we want to encourage United Ways and service providers to think more about how they can apply trauma-informed care in their work. So in that regard, I'm going to share the results of a series of in-depth interviews I did with representatives of Siemer network organizations that integrate trauma-informed care into their work. So to start, let's define trauma-informed care in this context. As you can see from the definition here, trauma results from events or circumstances that are physically or emotionally harmful. So things like losing one's home, or experiencing domestic violence, or losing a loved one to violence, all of those are obviously terrible, stressful, negative events. But they are not trauma in and of themselves. The trauma is really what results from and what is experienced after these events have already occurred. So basically, you can think of this as terrible events or negative events causing trauma. The reason that distinction is important is because it helps explain why different people may have very different reactions to the same negative events. They process and deal with the traumatic after effects differently, and thus their behavior is different. Also, I'd like to point out that the events, at least under this definition, do not have to be massive, one-time, disastrous occurrences. Rather, the accumulation of undesirable events can also add up to trauma. So as one of my interviewees suggested, the experience of living in the United States in poverty, or as a minority, can be traumatic for people over time. So the cumulative effects of how they're treated at their children's school, or on the bus, or at the bank. So that gets to the chronic circumstances that can lead to a trauma reaction. So what is trauma-informed care then? One way we can define that is the definition you'll see on your screen, which I will read for you, a strengths-based framework that is grounded in an understanding of and responsiveness to the impact of trauma. That framework emphasizes physical, psychological, and emotional safety for both providers and survivors, and it creates opportunities for survivors to help rebuild a sense of control and empowerment. So this is the one definition that, from our review of the literature, fit most comfortably with the aims of homelessness prevention. It's not the only definition out there, but it does hit the common elements we saw in our scan of that literature. Why should we consider this model at all? Why is trauma-informed care important? We think that's because there's considerable evidence that homeless individuals have experienced trauma. So some academic studies suggest that between 79 and 93% of homeless mothers have experienced traumatic events in their past and that they may be suffering the after effects of that trauma. Additionally, and obviously, the reasons for homelessness are often trauma-related. So a lot of the things that cause families to become homeless are in and of themselves related to trauma. Things like domestic violence or abuse, loss of job, a major disability, are all examples of these reasons that could lead to traumatic effects on their own. And then finally, And again, obviously, becoming homeless is also a traumatic event in and of itself. So, for all of these reasons, we think it makes a lot of sense to consider trauma informed care when planning your programming efforts. So, what I want to do now is return to the definition we just offered a second ago and focus in on some of the key elements of that definition. The first of those elements is that trauma informed care is a strengths based framework. I think you're probably familiar with strengths based frameworks, so I'm not going to dwell on this too much. We'll also return to it a little bit at the end of the webinar, but for now, what I want to point out is that a strengths based approach is fundamentally focused on the resources that the client does have. What strengths can they draw on? What abilities do they have that they can use to help better the situation of themselves and their family? It's central to a trauma-informed care approach, and that's a good thing because it helps build resiliency and counter the negative self-images that some of the clients you work with undoubtedly have. Sometimes, as you probably are aware, you may have to be creative in helping clients recognize the strengths that they have. So it could be something as simple as getting their kids to school every day for a week on time. It can be thinking about skills that they have in their lives that aren't directly related to their professional success or their current job. For instance, one interviewee shared a story about a woman who was a very good baker who was able to make some extra money selling the baked goods that she made in her home. This framework also has parallels to other best practices. So trauma-informed care is reminiscent of and wholly compatible with other holistic approaches of family engagement. Those of you who joined us for the 2Gen webinar presented by my colleague Ori Christel will hear echoes of the techniques we described there in the discussion today. Specifically, both are strengths-based, and both frameworks share an emphasis on goal setting and choice to involve clients in case planning. Again, I'll get to that aspect a bit more later, but for right now, I did want to share with you that one of the evaluation studies we located suggested that combining trauma-informed care with two-generation programming can actually lead to exponential benefits for clients and case managers. So returning to the definition, I would like to just focus on the next element we're going to highlight today, and that is trauma-informed care requires an understanding of and responsiveness to the impact of trauma on the people around us. And I deliberately say people around us there because we don't want to focus only on clients, but also on our coworkers, and we can even extend this knowledge further into our lives outside of the professional domain. So, what are the principles of trauma-informed care? First, trauma-informed care is a culture. It requires an understanding of the impacts of trauma throughout the entire system. We're not going to get into too much detail today about the specific impacts of trauma because that's a much longer conversation that requires expertise in the clinical or counseling domain that is too much ground to cover in one webinar. But what I do want to point out is that those impacts have to be really understood throughout the entire system of care because they have implications for everybody. At its most basic level, what we really want to do, though, is to encourage people to step back from whatever behavior they're seeing with clients and flip the focus. So instead of asking, what is wrong with this person, instead focus on the question, what has happened to this person to cause this behavior? In all of the interviews I did, this question came up, and this lens is incredibly important for case managers and for other staff working in a trauma-informed care context. The primary goal of trauma-informed care is to avoid re-traumatizing clients. That can mean avoiding triggers that are specific to the trauma history of an individual. For instance, perhaps an assault survivor prefers never to meet in a room with a closed door. Or it can require attention to more macro-level trauma, issues related to race, gender, ethnicity, or class. So as I mentioned before, one interviewee told me clients are traumatized not only by individual experiences, their childhood, for example, but they're also consistently re-traumatized from living in poverty, utilizing social services, how they're treated in schools, as a parent, and on city buses. She suggested this is especially true when they have a lot of experience working with agencies that don't always view them in a positive light. Clients can internalize a negative view of themselves, which makes future progress much more difficult. Re-traumatization probably partly underlies the difficulties that clients can have engaging in programs that can benefit them. And attention to this issue, to avoiding re-traumatization, can remove one roadblock that clients face. So when we think about transitioning to a trauma-informed care approach, what are the things we need to keep in mind? The first is that you must obtain appropriate training. This circles back to my earlier comment where I suggested that we couldn't cover all the impacts of trauma in one short webinar. Training is very critical, and it's usually widely available in most metropolitan areas at least, and certainly seems to be available to many programs throughout the Siemer network. The training should be in-depth. It should really arm you with knowledge about how trauma can impact people and how you can expect people to react in the wake of experiencing traumatic events. So one of the interviewees I talked with shared the experience of having a few people learn some catchphrases from trauma-informed care and think that they understood everything there is to know about it. But trauma-informed care can be difficult to apply, and sometimes you can't always predict the effects of trauma on individuals. Additionally, the framework of trauma-informed care doesn't always apply to all subgroups. So for instance, as we'll talk about later, one of the key principles of trauma-informed care is to help people become more self-assured and in control by offering them choices. But if you're working with a client who has a history of domestic violence, making choices can be very difficult for them. And so in their particular case, the trauma-informed approach may not be offering many choices or encouraging them to make choices. These are all things that you can consider once you have a solid background in the impacts of trauma and what trauma-informed care means. A second step toward transitioning to a trauma-informed care approach is assessing your organization's starting point. There are many online assessment tools you can find. Those are listed in our issue brief, which will be made available. They all focus on looking at the different aspects of your organization and approaching each of them through this lens of trauma-informed care. So constantly asking, is this organizational component likely to re-traumatize an individual? Is there any way we can make this component easier for people who may be dealing with trauma? Additionally, trauma-informed care really needs to be implemented throughout the entire system of care. So this is from the front desk staff to the director, to the person that they might walk by in the hallway when receiving services. It's very important that all of those people understand the potential impacts of trauma and be ready to alter their approach to clients based on that understanding. One way to facilitate this is to really explain the why of trauma-informed care to staff and partners. As we've noted, consistency is critical. In order to really implement system-wide change, you want to, of course, be on the same page with your staff, but it's also helpful to be in touch with critical partners. So explaining why you are implementing trauma-informed care can help them understand the benefits of this practice and encourage them to implement it as well. Stressing the positive benefits it brings and the fact that those benefits are actually for everyone they come into contact in, not only those with a trauma history, can help. So one thing I like to do is think of this as sort of a universal design for the social services. When we think about universal design in physical spaces, it's a principle that suggests that making buildings and physical spaces accessible to those who have a physical disability can also make things easier for folks who don't have a physical disability. So think about the buttons that we use to open doors for people in wheelchairs, also benefiting moms who are entering doors with strollers. In a similar way, trauma-informed care is especially beneficial for individuals with a trauma background, but it's also helpful for all the clients and all the staff you will come in contact with. Another step to transitioning to a trauma-informed care approach is to consider training for your clients, people most impacted by trauma. One of my interviewees said that they regularly do psycho-emotional workshops with clients. Those are facilitated by clinical staff, and they even extend those workshops to children of clients. These workshops help people understand the effects of trauma on themselves and on people they love so that they can potentially intervene to change dysfunctional patterns. Again, this links us back also to a two-generation approach. So when approached at an age-specific level, you can simultaneously train both parents and children on the impact of trauma and help to break habits that may be forming or have already formed in the family. Returning to our definition, the next piece I would like to highlight is the idea that trauma-informed care emphasizes physical, psychological, and emotional safety, not just for clients, but also for providers and any staff who are working with clients. So when we talk about this, always, always, always in the back of our mind, we want to think about safety and security, not just for clients, but also for people on the service provision end of the equation. So how do we go about encouraging clients to feel safe and encouraging staff to feel safe? The first thing is an attention to physical space. So when you're meeting with clients, you want your physical spaces to be secure, but not necessarily clinical. You can consider adding homey touches and also offering different settings so that if one client prefers to meet privately with a door closed, that's possible. But if another client prefers a more open space, that's also doable. Similarly, providing some choice for who people meet or work with can be useful. That's especially true for survivors who have some kind of assault in their background who may feel more comfortable working with one gender, for example. You could come up with unlimited examples of ways that those combinations could play out. Several interviewees noted that clear indicators of safety, like cameras and security guards, are definitely necessary, but also cautioned that this can be difficult if interactions with those kind of staff members or feelings of being monitored are part of someone's trauma background. And I think this highlights an important point, which is that not all features can be helpful for people with trauma backgrounds across all people with trauma backgrounds. So sometimes you will be considering very unique interactions. And in those cases, to buffer effects on people who are struggling, you may consider trying to change the location of the meeting altogether or to help make other accommodations that are trauma-informed. That is, a blanket approach, especially to physical space, isn't always possible. One interviewee shared an experience with a very minor change that helped her organization move forward on the spectrum of trauma-informed care. At this organization, staff primarily met with clients on the upper floors of their building, and if a client became emotional or frustrated during a meeting and left the office in what I'll call a less than calm manner, they would exit the second or third floor via stairwell, which did not have clear signage to the building's exit. If the client wasn't paying careful attention, he or she would end up in a dark, empty basement and potentially become even more frustrated or even triggered by the idea of ending up in that environment. So one simple change they made to help their physical space be more trauma-informed was prominently marking the stairwell door for the building's exit. This lessened the potential for trauma that clients would experience in such situations, and is also a great callback to the universal design idea that I just talked about, which is that it also makes it easier for people who don't have trauma to know where they can exit the stairwell. So we're talking about a rising tide lifting all boats in terms of making interactions easier for everyone which especially benefits folks who may have a trauma background. That covers physical safety. What do we consider when we think about psychological safety? From my interviews and from my research, I think that trust is the key to psychological safety. Trust will help case managers better understand clients and help improve client functioning. And again, this translates not just to the clinical relationship between the case manager and the client, but potentially also to other interactions in society at large. So if a client can learn to trust the case manager to do what they say they're going to do, they may potentially be able to extend that trust to other people and other situations. This echoes the idea that trauma-informed care can help us break potentially ineffective cycles that clients could be engaged in their interpersonal reactions. So how do we do this? How do we get clients to trust us? I think you all have more experience in that than I do. But what I would offer based on my interviews is that you keep all commitments. And even as important or more important, if you can't keep a commitment, explain why you can't. So most people don't trust when commitments are broken because they don't have an understanding of why they're broken. If you can't keep your appointment, that's not the end of the world. Just be sure to explain to your client why so they understand. Additionally, we have to give clients time and space to express themselves at their own pace. So while you should be considering trauma from the beginning of your first interaction with clients, don't probe explicitly on it and don't expect them to necessarily disclose it right away. Once clients know you'll show up for them, they'll be more willing to disclose. And once they disclose, you'll know what to do with that information. Finally, and an important theme that we're going to come back to, and you should consider in all of your trauma-informed care planning, is maintaining appropriate boundaries. This means both in terms of knowing your role, which is likely not a clinician unless that is the role you hold, and also holding clients up to some standard of accountability. So when I say understanding your role as a non-clinician, that means you're not expected to resolve the effects of the trauma for the individuals you're working with. It's not your job to counsel them through it. It's your job to know what they might be experiencing and to do your best to tailor your services and your approach to be compatible with that. Additionally, maintaining boundaries for clients is incredibly important. In fact, I would say that the importance of that really can't be overstated. So no matter how much you understand why a client is behaving in a certain way, which a trauma-informed care approach definitely asks you to do, if the behavior is unacceptable, it is unacceptable, full stop. It doesn't help clients to set up unrealistic expectations in the service of being understanding of their past experiences. We want to be understanding, but we can't allow them to violate all the rules because we know where they're coming from. It also doesn't serve other potential clients who may be missing out on services because the person you're working with who's having a hard time engaging is holding a valuable spot in the program. So boundaries came up a lot in my conversations with experienced case managers who are using a trauma-informed care approach. And I think that's because there's a fine line between implementing good trauma-informed care and enabling negative behavior. Once you step back from saying what's wrong with someone and instead shift to saying what happened to this person in the past to cause this behavior, you will naturally be inclined to want to at least understand, if not excuse the behavior. But maintaining critical boundaries is important for the client's growth. Additionally, boundaries can help case managers and other staff avoid some potential negative downsides of trauma-informed care, which I'm going to talk about next. So when we talk about potential negative impacts on staff, I think there are two primary things to be concerned about. The first is secondary traumatization, and the second is compassion fatigue. People who suffer from secondary trauma have either triggered their own traumatic experiences in their background or have experienced trauma themselves because they've heard about the traumatic experiences of others. So the person experiencing the trauma is primary, but listening to recounts of behaviors that or experiences that were traumatic is also hard to do, and we have to be aware of that. Compassion fatigue is very related but different from secondary traumatization. So it's a state experienced when people who are in helping professions have a state of tension and preoccupation with the suffering of those being helped to the degree that it can create a secondary traumatic stress for the helper. You are probably familiar with these terms, but they're especially likely to occur in a trauma informed context because we're encouraging staff to take on the role of listening to and understanding client trauma. Related to the boundaries discussion we just had, one way to help minimize these impacts on staff is to encourage them to try to help clients take a step back from their own trauma. So once you know that a person has a traumatic background and you understand what some of the impacts of those trauma are, you don't have to hear about the events that caused them every single time you meet with the person who's experiencing them. It can be difficult to cut people off when they're talking about things like that, and it's important to make sure you retain a sense of empathy in your approach to people, but gently communicating that your client does not have to relive their trauma is useful for both clients and case managers. It helps case managers avoid these two negative impacts, and it helps clients learn to move past the specific negative events, recognize how that could be impacting their behavior, and again, break the negative cycle that we've been talking about throughout the entire webinar. What are some organizational solutions to these negative impacts on staff? First, several interviewees mentioned that one-on-one supervision with case managers to their supervisors is incredibly important. Case managers need the opportunity to release stress. They need to be able to share the events that they've heard and that are causing them trauma, and they need to be able to process those with a safe person. It allows them to release the tension that builds, hopefully avoiding compassion fatigue and secondary trauma. Additionally, staff need time and spaces to decompress. This means they need to have places where they can go to have quiet downtime, but as importantly as that, they need to have permission to retreat when they need to. One of the unique factors of trauma-informed care is that you can't really provide trauma-informed care unless you're prioritizing self-care. You have to be in a place where you can devote energy and resources to understanding the impacts of trauma on others, and you simply can't do that if you don't have time and space to decompress for yourself. Additionally, it's important to look out for attention to signs of strain on the part of the organization. These can be simple things like expressions of anger or expressions of stress, but they can also be more subtle, like suddenly seeing an increase in absenteeism from a formerly very reliable employee. So paying attention to signs like disaffection in meetings, not honoring commitments, etc., can help you head off the negative impacts of secondary trauma and compassion fatigue among case managers. Finally, and as I already mentioned, case managers and other staff interacting with clients who've experienced trauma must prioritize their own self-care. This means both knowing where you are on your own journey with whatever trauma you may have experienced, and it also means taking time to relax and recharge when you can. Now I'd like to move on to the final component in the definition that I'd like to discuss, which is that trauma-informed care creates opportunities for survivors to rebuild a sense of control and empowerment. Again, this is going to harken back to the two-generation approach and probably to some of the case management strategies you already use. But instilling a sense of control and empowerment is crucial for helping clients with traumatic experiences in their background overcome the impact of that trauma. One way to do this is to help clients identify, remember, and even celebrate strengths and small victories. This keeps them invested in the goals that they are working toward, and recognize them as the experts in their own experience. You're going to be called on to take an active role in this. Clients are not always going to be able to identify their strengths, and so part of your job is going to be to do that for them in a trauma-informed care approach. Draw on client expertise when you can. One interviewee shared an anecdote with me whereby whenever she's facing a situation with a client and she's not completely sure how to navigate it, if she has a client who's had a similar experience, she will often call them on the phone and ask for their advice. This lets the client know that you respect them, that you recognize your strengths, and also makes your job a little easier if they have a suggested solution for you. Additionally, set goals. This is something you all do in your regular case planning, but it's also helpful to have the client set their own goals and be invested in their journey. You may have to help your clients break the goals down into very small steps. For instance, some programs may have a very lofty goal of helping a client complete college. That obviously relates to many smaller steps along the way, and having one large goal can be overwhelming for clients. So consider adding in milestones or steps toward the goal, which will help you again focus on client strengths and celebrate their victories, even if the ultimate goal isn't fully complete. And then finally, and perhaps the biggest arrow in your arsenal in terms of encouraging people to take control of their lives again, is allowing choice. So provide choice whenever you can. This can have a special impact for clients who are typically served in homelessness prevention programs because they're probably familiar with receiving assistance from many other social service agencies. And in many of those contexts, they may have little to no choice about the services they are receiving. Helping clients access choices, helping clients make good choices is inevitably going to build a reservoir of empowerment in clients because they know they can make choices, fulfill their goals, and move forward in their lives. One interviewee shared with me that she regularly uses Siemer funds to provide beds for children and adults in the families that she works with. She suggested that allowing those clients to actually select the bed they purchase was huge for them in terms of regaining a sense of control over the situation they found themselves in. Took her 15 extra minutes to allow them to make that choice, but that time was repaid immensely when she had less work to do with the same client because they were able to work toward their goals more independently. And many of these folks have never had that choice. They get whatever bed shows up in their apartment. So just allowing them to make simple decisions is incredibly helpful. So basically, the three key insights I want to share with you today, I'm just going to go back over those again. The first is that trauma-informed care is a system-wide approach that is compatible with other best practices. So it can be applied from the front person who works the front desk to the case manager who works directly with clients, all the way up to the CEO or the CFO or the people in charge of grant writing. Always keeping in mind the potential impacts of trauma on the clients you serve will lead to better outcomes for them. It's also compatible with two-generation approaches, which emphasize strength, choice, and goal setting, and ultimately help lead to the same goals of client empowerment and improvements to their situation. Practitioners who employ trauma-informed care must pay careful attention to boundaries and self-care. Talked about this a good deal, but I really can't emphasize enough the need to be sure that you're walking the fine line between helping clients and enabling clients in a trauma-informed care context. So, no matter how much you understand the behavior a client is displaying, you must also be willing to enforce whatever basic policies and guidelines your organization employs. Clients have to know what behavior is and isn't acceptable, and they're relying on you to make sure that that's carried through. Finally, we recommend appropriate training and organizational assessment as necessary conditions for employing trauma-informed care. Organizations should consider not just how their case managers work with individual clients, but how their physical spaces are organized, what kind of choice clients have in selecting specific services to participate in, and how their goals are structured. You can find several different websites online that will help you perform an organizational assessment by answering some questions. And again, those are listed in the seminar, in the issue brief. But some kind of overview of how your organization currently is functioning and setting goals toward how you'd like to move is necessary. And again, appropriate training is widely available and is definitely a necessary condition for being sure that you fully understand trauma and how it may potentially impact the work you do with clients. So what I'd like to do now is turn this all over to you. I want to know if anybody has any questions that we can answer for you or do our best to answer for you.
Thank you, Amanda. So what I'd like to propose, since we have a lot of people on the line today, is I'd like to ask you to put in the chat box to everyone either that you have a question to ask and just state your name and that you have a question and I can call on you, or if you'd like me to ask the question for Amanda to respond to, I'd be happy to do that. So do we have any questions? So far, nothing. You covered everything.
In the meantime, I want to extend a thank you to the folks who graciously shared their time with me by phone to talk about how their programs are incorporating trauma-informed care. And I wanted to point you toward the issue brief because it contains a lot more detail than we were able to get into the call here. But those folks were Christy Adams, Angela Burney, Carolyn Shire, Julie Radican, Sarah Reshley, and Amanda Wilton. And I hope I can speak for them and say that I think they would be willing to talk with you if your program encountered any obstacles in trying to implement trauma-informed care in your own local area. The other thing I can share with you, if no one has any other questions, are some key educational resources. So the three biggest organizations who do work in this area that were useful for my review and the issue briefs that we constructed were the Substance Abuse and Mental Health Services Administration, the National Center for Trauma-Informed Care, and then also the Institute on Trauma-Informed Care at the University of Buffalo, which was recommended by one of my interviewees. So I'll leave that screen up while we see if there are any questions.
So one question that was asked is, where can we find the issue brief? So just as we have presented the two-generation issue briefs, and thank you for forwarding this slide, in the Resource Center and on the Siemer Institute website, you can find that information under familystability.org/research and reports. And remember that this, just as with the two-generation issue briefs, there are actually two briefs. So the first brief will have more of a definition of trauma-informed care and really break that out for you specifically. And then the second brief is the application. So the second brief has all of those examples and the insights that the team at Illuminology learned from all of the interviews.
And there are some really rich details in there that I think is worth spending the time to check out. Again, all thanks to the interviewees who helped with those.
Well, if we have no more questions for today, I just want to thank everyone for spending some time with us. And thank you very much, Amanda. It was a fabulous webinar as usual. Illuminology has done a great job. We look forward to seeing everyone in October. October 15th through 17th is the National Siemer Summit, Siemer Institute Summit, and we will once again be in Fort Worth. And to follow on from the work that you just heard just a little bit about today, trauma-informed care is going to be the theme of our summit this year. So last year we focused a lot on two-generation or multi-generational work at the summit, and this coming year we'll focus on trauma-informed care and many aspects of that work. Thank you, everyone. Have a great afternoon.